So welcome everyone. Thank you so much for joining us for this webinar with Dr. Prati Sharma, who I really thank for joining us tonight. I am Isabelle Lefebvre-Vary, and I am the Executive Director of Fertility Friends Foundation. We are a Canadian registered charity, and we offer grants to cover expenses associated with fertility treatments, IVF, egg and sperm donation, and gestational surrogacy. We are very happy to have this webinar tonight as part of the Canadian Fertility Awareness Week, CFAW, which is the most important week of the year for the fertility community, where we all gather, share stories, and create more awareness about fertility and fertility treatments. This webinar tonight is part of our webinar series called Your Fertility Guide. It's a new series that we launched a few weeks ago. We organize now one webinar per month on various topics, all related to fertility, to bring more educational content to our community. So you can check it out on our website. You'll see the schedule of the upcoming webinars, and we strongly encourage you to register for the next ones. But back to tonight and back to Dr. Sharma. Thank you again for being with us. Dr. Sharma is a fertility doctor. So I think the real way to say it is REI, reproductive endocrinologist and infertility specialist. She's a fertility doctor at CReATe Fertility, which is a clinic in Toronto. And she's also a director of our board. She's a very valued member of our community and a strong advocate for a more equal access to fertility treatments. I have to say, and I'm sure that you're gonna agree with me, Prati, that it's a mission of yours to make sure that everybody has access to fertility treatments. And one of the biggest barriers is a financial one, and that's why you decided to get involved with us, and we are very happy that you decided so. So the way it's going to work tonight is that Dr. Sharma is going to make a presentation. She is very happy if you'd like to post questions in the chat during her presentation. So I could ask the questions to her and she could answer them on the spot. It's maybe more interactive than waiting until the end of the presentation to do so. So feel free to post your questions in the chat and I will make sure to relay them to Dr. Sharma. Thank you again, and the floor is yours.
Well, thank you so much, Isabelle. It's my honor, actually, to kick off this webinar series, and so early on in the CFAW week. I couldn't be more thrilled to be a part of this organization. And yes, it is certainly a mission of mine to promote equitable access to high quality fertility care in a financially reasonable fashion for all of those who want to build their family. It's really one of our reproductive rights. So the topic today is Fertility 101, understanding your options and when to seek help. And so given this was the opening webinar, I wanted to sort of touch upon all things fertility related, because I assume many of the audience are potential patients, current patients, prior patients, patients at another clinic, and many of your questions kind of surround your particular diagnosis and what the treatment options should be. So I tried to highlight a lot of different things. Hopefully I didn't miss anything, and feel free to jump in and post questions because, again, I would like this to be interactive rather than didactic with my giving a lecture. So I'm pretty easygoing. If you know me at all, I'm on social media and I like to post information that is really digestible for patients so that they really can understand and take charge of their journeys. So as Isabelle very well alluded to, the purpose of this week, Canadian Fertility Awareness Week, it happens once a year, really important week for our community, raise awareness, to normalize the conversation surrounding infertility, highlight the importance of seeking care early. And I think, and I'll touch upon this in subsequent slides, historically it was that you had to be diagnosed with infertility before you would seek fertility care. And now it's really all about having options and being proactive about your reproductive health. So there's no wait time. You can see a fertility specialist whenever you want, even if it's just a touch point to get a pulse on where your fertility lies. So make sure that we have access to fertility care and family building in all communities. The LGBTQ plus community is very important to us, and we want to make sure we outreach that community as well as other maybe marginalized communities that don't have the same resources and access that others do. Financial options, that's where Fertility Friends really comes in terms of assisting with fertility treatment. We've come so far scientifically, but the coverage for fertility care has not come as far as we need it to be. It's certainly improving, and I'm always very impressed at how quickly Canada is going on a positive slope as opposed to a negative slope compared to maybe our neighbors across the border. So I think this is all really positive, good stuff. Mental health and well-being, this is really an important one. I think even though this is a medical field based on science, we can't underestimate the anxiety that's associated with going through infertility treatment and trying to build your family. Lots of treatment options available. We're lucky to be in this day and age. And so CFAW is also to discuss all the different treatment options that are available. And whether you're trying to conceive now or later, you could be right in the game right now trying to have a baby, or maybe you're not ready yet. So to talk about things like fertility preservation, even if it's elective because you're not ready to conceive now because you're pursuing other interests, and share stories. I'm so happy to see so many patients who are really speaking out loud, talking about their journey, whether it has ended in a positive outcome or not, and helping us improve the patient experience and making sure that journey is also a good one. So just some background, infertility is incredibly common. The WHO recently published a study showing that 1 out of every 6 people will experience infertility in their lifetime. And in Canada, it is 1 in 6. So that is a very high prevalence, probably more or higher incidence than certain other medical disorders. So we really need to bring infertility to the global stage and make sure awareness is increased, and we have support systems in place to help those who struggle with infertility. Why is this happening? Well, probably many of you saw the article that was posted many times on social media that for the first time, more babies are born to women over 40 than in their teens, which is kind of interesting because historically it's always been a struggle to get contraceptive methods out there, and teen pregnancies were a huge problem in North America. But now I think contraceptive access, thankfully, is really great. That message has come out, and teens are also very much aware. There's education in the schools. So if they don't want to get pregnant, they're not getting pregnant. And women are delaying childbearing. They are not having kids till later in life. They're waiting for the right partner. They're pursuing other avocations. And with the advent of all these great fertility treatments, namely IVF, patients are pursuing IVF at later ages and being able to build their families. So motherhood later in life is actually very common, and we're seeing it in the data. So that's, good and bad. I think we need to strike with the times. And I think women are just like really equaling men when it comes to professional goals and being hugely important on the entrepreneurial and professional limelight. And so they're delaying childbearing, but they're also having kids, which is great. They're able to do it all. So let's go back to some historic definitions. So historically, primary infertility was defined as the inability to conceive after 1 year of regular unprotected intercourse. For women over 35, that was slated to be 6 months because of the age factor. Secondary infertility is the same thing, but with a prior conception, whether that be a term or preterm birth, miscarriage, abortion, ectopic, or neonatal loss. Again, 6 months for 35-plus-year-olds. This older terminology is really not so relevant in today's society where access to fertility care is readily available and patients are taking a more proactive approach to their reproductive health care. And so there's really not one perfect time to say, now you're ready to seek help. You don't need to wait the year. You don't need to wait 6 months. But if you think there's something going on or you just want to check your fertility, you're absolutely available to self-refer or have your doctor refer you to a fertility clinic. So let's start with the basics. What to look out for when you're trying to conceive naturally. Because if you keep your mind on these things, then if something is out of sorts with this list of things I'm going to tell you about, then those are reasons to come to a fertility clinic sooner. So even on day one, when you're trying to conceive, you should be thinking about whether your cycles are regular. Do they come monthly with a normal range of every 28 to 34 days, lasting 3 to 7 days with normal menstrual flow, not too light, not too heavy, and tolerable pain levels. If your cycles are over 35 days apart, or you're not getting cycles, if they happen every 2 months, or you're having severe pain, this is not normal. Seek help sooner. Are you able to track your ovulation, and are you familiar with your fertile window? So lots of stuff is out there, menstrual calendars, apps, some people use cervical mucus symptoms. So if you can reliably tell your ovulation window, then you're having accurate timed intercourse to conceive. But if you have no idea when you're ovulating, even with using these trackers and apps, then perhaps it's because you're not able to pick it up with at-home kits, or you're having irregular ovulation. And again, that's a reason to come to the fertility clinic sooner without waiting the 3, 6 months, 12 months. Are you able to have timed intercourse every day or every other day during your ovulatory window without difficulty? So these are patients who perhaps have vaginismus in the female, erectile disorder, painful intercourse. If you're not able to go through the whole process where there's intercourse and ejaculation and sperm is entering the reproductive tract, again, another reason to seek help early. Are you over 35? Do you have a family history of infertility or premature menopause, ovarian failure? Absolutely come in sooner and see us. Is there a history of male factor infertility? Lots of focus these days on the male, and I think that's very important because they make up 30% of the reasons for infertility. So we can't just ignore the male piece. So if there's a family history of male factor, another reason to be seen early. Are there any hereditary genetic conditions in the family? I see a lot of patients in my practice who, because of their ethnicity, they have either had testing. Now there's a huge push for doing genetic carrier screening as part of preconception counseling to know if you and your partner potentially have matching genes that can pass along to a fetus. And so if you know there's something in your family or there's a family history of some genetic disorder, you should potentially get tested and potentially consider treatment like IVF and screening your embryos. Another reason to come in early. Are you looking to have more than one child? Let's say you're starting your family at 35 and starting to try naturally, but you know you've always wanted 3 kids. Obviously, that's going to be potentially 35, 37, 39, maybe even 40 plus. And so if you want to build a larger family, we know that women's eggs get older as they get older. And so perhaps you want to intervene and do something like IVF and freezing embryos sooner so you have the opportunity to have another child later. Personal story, I had my 3rd child at 42, almost 43. And the reason I was able to do that is because I expedited and did IVF sooner at a younger age, which allowed me to have a biological child later when it might have been more difficult. Any family history of miscarriage or repetitive miscarriage, there can be a hereditary component or a medical disorder that can cause this. So a reason to get screened sooner. Is there advanced paternal age? So again, back to the male. For men who are over 40 and particularly over the age of 45, we know that sperm quality diminishes and advanced paternal age can be associated with things like autism. And so again, a reason to get seen sooner. Is there a medical condition or have you had prior surgery that can affect your fertility? An ovarian cyst that was removed can reduce your ovarian reserve. Do you have chronic hypertension, diabetes, lupus? All of these things can really impact your ability to conceive and even your ability to carry. Are you not ready to conceive now due to XYZ factor and you need to freeze eggs or embryos? These are all reasons to seek help sooner. So let's look at the causes of infertility. So this sort of pie chart is, believe it or not, just from Wikipedia, but it's pretty true. So there's female factor, that's 1/3 of infertility, male factor, that's 1/3, combined male and female factor, 10%. Unexplained is a huge part of infertility, 25%. And so this sort of outlines all the different causes, female factor, male factor, unexplained, and you can read them here. Without going through each one, I will be talking about each one in a little bit more detail, but there's a number of things that can be in each of these categories. So what is the testing that's going to be done during a fertility evaluation? So history is the first step. So it's really important as a fertility doctor that I get to know you at our initial consult, that I know about your menstrual history, your OB history, if you've been pregnant before, your gynecologic history, gynecologic symptoms, medical problems, any medications that you're taking, toxic habits, your body weight, any previous treatments that you've undergone. So really, I get a lot of knowledge about what the diagnosis could be just by doing a good history. Ideally, if there's two partners, whether it's two men, two women, a man and a woman, I'd like to talk to both of you so that I hear the full story. In terms of testing, general testing is for a woman, it's pelvic ultrasound, egg count, AMH fertility test, day 3 blood work, reproductive hormones like the TSH and prolactin, and a test of the tubes and or uterus. For the male partner, it's a semen analysis and potentially extra sperm tests or genetic tests if needed. Depending on your diagnosis, sometimes we'll do additional screening tests to dive deeper into what your treatment options are and what your diagnosis could be. So just a picture showing sort of the tests that we do for maybe those patients or potential patients that are online who haven't actually entered the fertility clinic yet, and they're in what we call the preclinical phase. So a pelvic ultrasound is at the top, my left, which is just this ultrasound, and I'll use my pointer here. That's a picture of the uterus, and that's the bladder. This is a sono test, which is putting fluid into the uterus, which is this pear-shaped organ, to make sure there's no bumps or lesions within the uterine cavity that could interfere with implantation. This is also a pelvic ultrasound. This is a transverse view of the uterus. This is the ovary here, and the small box circles are the follicles. Over here is a hysterosalpingogram, which is an X-ray dye study of the uterus, which is this oops, sorry, I didn't mean to do that. Triangular shaped organ, and you can see the tube spilling on the other side. I have the semen analysis, a basic semen analysis. It's looking at count, motility, shape of the sperm on the right over here. And on the bottom is AMH, which is a fertility hormone. It's really our gold standard for egg number and egg reserve. And so this unit is in nanograms per ml, but in Canada, we often use the picomoles per liter units. So these numbers are a little different from what you might see in your clinic. You can multiply them by 7, and that gets you the units that are described on the right. So let's dive a little bit deeper into each of the diagnoses, and sort of the way I wanted to do this is talk a little bit about the major diagnoses and why it's important to identify them early and seek care early, so that you can have lots of options at your fingertips. So reproductive aging and advanced reproductive age is probably one of the major diagnoses that we see in the clinic, and this is why women are having babies over 40. So this slide is from the CDC SART database. It basically shows that as a woman gets older, which is on the x-axis, pregnancy rates go down with her own eggs. And you can see pregnancy rates are pretty good in the 20s and 30s. And then once you get to 40, they really dramatically start dropping down. And that's due to egg reserve, so number of eggs, and quality of eggs. Because as women get older, their egg number goes down and the number of genetically normal eggs goes down, which makes you less likely to be able to conceive a healthy, viable pregnancy. Over 45, the IVF success rate is documented to be probably less than 1% and even close to 0%. So, there's not that much room between 40 and 45 to be seen sooner to get in. So it wouldn't be unheard of, and I certainly would not have a problem with someone who is 40, who meets their partner later in life and is ready to start trying at 40 years old, day 1 of trying, if in parallel they make an appointment with the fertility doctor to check things out. And that's not waiting a year, that's not waiting a month or 2 months, that's getting in to be proactive. And then one of the tests the test that we'd order for ovarian reserve testing is AMH, day 3 blood work, and antral follicle count. It is important to identify low egg reserve early, and we talk a lot about age-related ovarian reserve being low, but I have seen 35-year-olds, 33-year-olds in my practice who have low egg reserve. So sometimes it's just the individualized patient. For whatever reason, their ovarian reserve is lower than what would be expected for their stated age. And, if you can find that out at 35 that you have low egg reserve, you might choose to pursue more aggressive treatment like IVF and fertility preservation sooner so that you don't have to worry at 40. So male factor infertility, very common. Recently, there's been an increased focus on the male, which is great. Lots of focus on lifestyle modifications to eliminate toxic habits like marijuana and smoking use, increase vitamin intake. Early male intervention and evaluation is important because unlike females, men don't have menstrual cycles. So there's not necessarily anything on the outside that tells you if the sperm is abnormal. And so a semen analysis is really the only way. And so doing that early on can give you a snapshot of picture. We know advanced paternal age can affect sperm quality. Testing includes sperm analysis, DNA fragmentation index, possible additional urologic testing. We will consider freezing sperm. So if you are a male who's potentially going on a biologic or has a cancer diagnosis and is undergoing chemotherapy, we know those things can affect sperm quantity and quality. And so freezing sperm beforehand is relatively easy. And then you preserve your fertility and you can get coverage for that. Considering IUI in those cases of difficult intercourse, erectile dysfunction, vaginismus, consideration for IVF with ICSI if needed with male factor, and really identifying concerns early. Isabel, feel free to jump in if there's anything that pops up anywhere. Ovulatory dysfunction. This is probably one of the most common things we see. And I always say to patients, like, if you're not getting your period more than 3 times a year, so you're getting a period once every 3 months, like the likelihood of pregnancy is so low because there's only 3 ovulations as opposed to 12 ovulations. So if you knew at 25 to 30 that your cycles are way off and at 30 you're trying to conceive, there's already a problem there. So you need to come in and get that checked out early. No reason to wait. So PCOS is one of the most common causes. It's not the only cause of oligomenorrhea or irregular ovulation, but it's very common. And it's characterized by irregular periods, signs of high male hormones or hyperandrogenism, so facial hair, hair loss, extra hair growth, acne, and polycystic appearing ovaries on ultrasound. The good news is these people have very high fertility. You just have to get their eggs to develop properly. Early diagnosis is key because often these patients will have insulin resistance, pre-diabetes. Sometimes they have precancerous lesions of their uterine lining. They need to adopt, or they should adopt, lifestyle modifications like weight loss, diet, exercise, a body movement program to sort of optimize before they get pregnant. So there's lots to be done and lots that can be done early. Functional hypothalamic amenorrhea is another cause of irregular anovulation. And this is the runner, or the ballerina, or the gymnast who's super lean, super thin, and they don't ovulate because they don't have enough hormones in their body. Usually they have really low estrogen levels. And so we can quite easily get them to ovulate, but there's an underlying cause of them needing to gain weight just to have a healthy pregnancy. So again, lots to do for these patients and good to diagnose them early. Plus, if you're 18 and you're not even thinking about getting pregnant and you're not getting your period because you have this, the low estrogen can actually cause you to have bone instability and bone loss like in your 20s, and that's very dangerous. So you want to get to this early. Other hormonal disorders, hypo or hyperthyroidism, hyperprolactinemia, which is a condition where you have excess milk production from the breast due to high levels of prolactin. All of these can cause irregular ovulation. Really easy to diagnose with some blood tests, an MRI of the head for high prolactin. Thyroid is super easy to diagnose with the TSH, and treatment is pretty easy. And oftentimes, if that's the only thing wrong, you can restore normal menses pretty quickly and people can conceive naturally. But the other thing I say is, if you're coming in for irregular cycles, you might as well do the whole shebang, which is testing your partner if you have one, testing the tubes and uterus, because then you can uncover any other layers of infertility that we can get to and treat sooner rather than later. So tubal disease, anatomic factors, endometriosis, and fibroids. So this is all anatomy and implications on anatomic defects for your fertility. So anatomic factors such as blocked tubes, endometriosis, fibroids, adenomyosis can definitely affect your ability to conceive and carry. And these disorders might be present and active well before you're even trying to conceive. So early diagnosis can facilitate not only treatment planning, but also reduce disease burden and symptoms. So lots of people are like suffering with these conditions and they think it's just normal. This is just my cycles that are awful. But treatment early on can suppress the problem and treat it so that you're in better shape when you're trying to conceive and improve your quality of life. Again, a full fertility evaluation to look for other factors. For those with things like MRKH, which is not having a uterus because they have a birth anomaly that they were born without a uterus, freezing eggs or embryos early on and then waiting to find someone to carry these embryos is important. So doing that egg freezing and embryo freezing when you're young is going to give you better options for the future. So in any of these conditions, which are medical conditions that can affect fertility, there's consideration for funding to help cover fertility care. I practice in Ontario, and we do offer medical fertility preservation for certain diagnoses, and that's something you can speak to your doctor in clinic about. So genetic factors, I think this is something very en vogue and mainstream in the last like 5 years. Genetics has come so far. We have so many genetic screens out there for cancer profiles, for just general recessive disorders, for so many things. And so it is possible to be screened for many, many, many different disorders. And so with that has come an increased prevalence of patients coming to the clinic saying, I carry BRCA or I carry a recessive gene and so does my partner. We want to reduce the genetic burden to our children. And so these are indications to do IVF, extracting multiple eggs and creating embryos, and then testing each embryo to see if it carries the genetic disorder or not. And it's really revolutionized the ability to reduce genetic burden to progeny or children. And so I see a lot of these patients who are in similar ethnicities and they got tested as part of preconception counseling, found out they're both thalassemia carriers or sickle carriers or Tay-Sachs carriers, and we're able to screen out the embryos that are affected so that you can have a healthy child. Consanguinity is a big one too. We're in a cultural melting pot in Toronto here and in Canada in general. And so it is more common than one would think that patients are distant relatives or sometimes even close relatives, and that increases the risk of having the same genetic mutation. And so if you do have that, it is important to screen embryos for the genetic condition. So finally, I'd like to touch upon patients that have been on the journey for a really long time. And as fertility specialists, we all see these patients in our practice. So these are the prolonged infertility patients, repetitive implantation failure, repetitive miscarriage, multiple failed IVF cycles. And it's like a what to do. I've tried so many things. I've been to so many different clinics. And so I always say, I even say this to my own patients, if you want a second opinion, please go ahead and do that. There are so many different ways to do things. You can go seek out a second opinion if you'd like and bring that information back to me. I see many, many, many second opinions. In fact, today itself, I spoke to a patient who had a baby with me for baby 1 and then tried for baby 2 and it didn't work out. She went to another clinic and it hasn't worked there and she wants to come back to me now. So it is your care. Please, be proactive. You have to advocate for yourself. And so don't feel guilty if you need a second opinion in these situations. Make sure you've done all the correct testing. Sometimes there's out-of-the-box testing like immune testing, additional sperm testing, additional searching for things like silent endometriosis that are a bit out of the box and maybe not as traditional, tried and true evidence-based, but maybe that's where your diagnosis will lie and you can be helped. A different lab. Eggs and embryos sometimes do better or worse in certain labs. Trying a lab that maybe has experience with poor responders. Adding PGTA. Maybe it's time, excuse me, to move on to egg or sperm donation or surrogacy, and a different set of eyes will say, yeah, you know what, I'm looking at everything you've done, now it's time. Sometimes it's something potentially really simple that just getting deeper and deeper into the journey was perhaps missed. So a second, third, or fourth opinion is never a wrong choice. So medical or elective fertility preservation or third-party reproduction. So you may not be ready to conceive now, or perhaps you can't conceive now because of a medical diagnosis. So I would strongly urge patients to consider egg or embryo freezing, and I should also put in here sperm freezing for men. We have really come so far with cryopreservation of gametes, both eggs, embryos, and sperm. It's not considered experimental. It's considered perfectly scientific. Lots and lots of babies born from frozen eggs, frozen sperm, and frozen embryos. And so this is an incredible way to preserve your fertility if you cannot conceive now due to elective reasons, like you are pursuing a career in medicine, because you have a diagnosis that requires a medical therapy that prohibits you from being pregnant, or you're just not ready to conceive now and you're 35. So these are all really great ways to optimize and give you options for the future. And freezing at a younger age for eggs and embryos and potentially even sperm is always going to be better. If you are single or part of the LGBTQ plus population, obviously the concerns are a little bit different, and they hinge around requiring a uterus or an egg provider or a sperm provider. And so if you're in that population that needs an egg donor, sperm donor, or gestational surrogate, again, there is no too early time to seek information or assistance, particularly with finding an egg donor and more so with finding a surrogate. It can take a long time to be matched with these people. So starting that journey early, even if you're not ready to conceive today, is going to be very important so that you fit your timeline to have and build your family. So I know Isabel touched upon this, but coming from the doctor's perspective, we've made incredible strides in Canada where more and more provinces are supporting fertility journeys for patients, which is incredible, but we're still not there yet with universal coverage and access. And so IVF costs $15,000 to $25,000 per cycle, which is a really expensive endeavor, particularly if you need more than one cycle to create enough embryos for your family. Surrogacy and egg donation, particularly, and even sperm donation, has additional costs and can become even more expensive. Fewer than 50% of Canadian employers have fertility benefits. This is increasing. I'm on the board of CReATe Fertility, which has been coming into Canada. There's another organization called Progeny. They're trying to get employers on board to provide more benefits. So hopefully that'll change, but we know it's still, the struggle is real. And so that's why Fertility Friends Foundation provides grants to help assist patients in covering the expenses for fertility treatment. So we do have grants that are given out twice a year, right? Twice a year, Isabel, correct?
Correct.
It is twice, yes. And our grant platform is currently open. I've been filling out some applications recently. And so twice a year, we get tons and tons of applications. The fertility doctor puts together the story and submits the application. And then we, as our medical team, will review based on a very structured system to decide on grants that we can give out. We wish we could fund everybody. Unfortunately, we can't, but this is still a big step in the right direction. And we continue to give more and more grants and more funds with each cycle. So, I couldn't be more proud of what we do. So if you yourself need financial assistance or someone that does, please pass the word around about Fertility Friends. So thank you. That ends my portion of the talk. I'd like to say happy CFAW. The theme is Fertility Unfiltered, which means there's no wrong question, wrong comment. There's no too early a time to seek out fertility assistance. Like, this should be on the tip of everyone's tongue. And for consults, if anyone would like to see me at CReATe, you can send a referral to the clinic. Attention, Dr. Prati Sharma, please be sure to put my name on it so the referral comes directly to me. It's always great if you email my assistant who's been with me for 17 years. I feel like both my pregnant patients and the fact that my secretary has been with me for 17 years are probably my most prized awards. So Jasmine, her email is jasmine@createivf.com. I think I put her email on there, but if I didn't, I apologize. It's JASMIN at CReATeIVF, CReATEIVF.com. And please follow me on social media at Dr. Prati A. Sharma. Nice to see all of you. Hope this was helpful and educational, and I'm happy to answer any questions.
Thank you so much, Prati. It was very, very interesting, actually, and I learned a few things, so thank you very much.
If I taught you something, then I've really done something right.
Yeah. We have two questions for you in
Sure.
the chat, so I'll read the first one. In Ontario, can you advise why we have a long wait time for many fertility-related issues, such as fertility clinic, endometriosis excision, and surgery?
So, I mean, I think in terms of fertility clinic wait lists, to get in, yeah, they're still quite long, but in Ontario, especially in the downtown core or the GTA, the number of clinics is increasing. So yes, for certain clinics, it might be a longer wait list, or for certain providers, it might be a little bit longer. Like I'm not going to lie that my wait list is probably about 6 weeks or more, but now with more clinics opening, more providers, I think getting in is becoming a little bit easier. And sometimes, at least for my practice, if a patient messages me on Instagram and says, like, listen, I'm 43, I really need to get in quick, I try to like get them in a little sooner. So I'm hoping that not just in my practice, but in general, this is changing in terms of the wait list to get in. Surgery is a little different. So I think, unfortunately, OR time is precious in Ontario, and there is just not that much of it. That's one. And two, particularly for endometriosis, it's becoming very specialized to do that surgery. So, whereas in the past, healthcare providers in the reproductive space, like myself, we used to do endosurgery, but now I have given up surgery. Not that I was terrible at it or anything like that, but patients want to go to the person that does surgery all day, every day. So now these advanced laparoscopists, which are the ones that do endosurgery all day, every day, they're the ones, rightfully so, that are doing all the surgery, but it means all the patients are going to them. So their wait lists are quite long. The plus is that more and more the data is suggesting that if you have endometriosis, you can either manage it medically to avoid the reduction in ovarian reserve, or you can consider doing IVF sooner, because we know that endosurgery reduces ovarian reserve and banking embryos. So there are options to do things while you're waiting to have your surgical management. And we are pumping out more laparoscopic surgeons every year. And so hopefully, again, these wait times will come down. But I agree with you. It's not something that's super easy, and it's nowhere near getting surgery like getting surgery in the US, where you can be booked within a few weeks.
Thank you. And actually, Christine had a follow-up question. It was about how to make the family doctor aware that you want to go see a fertility specialist and create kind of a sense of urgency. But
Yeah.
if it doesn't work, you can always self-refer, if I'm correct.
Correct. Correct.
Yeah.
So, I mean, I would say we've come very far with family doctors. I've seen a huge increase in the ability of family doctors to say, if you go in and you say, I'd like a fertility consult, they'll just write the referral right away. When I first started here, I was seeing that family doctors would say, if you're 34, like, hey, you don't need to go yet. Wait a full year before you get a referral. But that's really changed. So I'm impressed. And I think that's a lot due to education. Fertility doctors are educating family doctors. Family doctors are educating themselves. They also are talking to patients about egg freezing and infertility. They're including that in their annual review of patients, right? Like, you go to the family doctor, they're like, how's your lifestyle? How's your weight? Do you have a family history of blood pressure? Now they're asking questions about family building. So I think that's changing. But yes, absolutely. You can self-refer to many clinics. The referral piece, to be fully transparent, is so that the clinic is able to bill. So in my practice, what I've started doing for patients just to get them in is they email my secretary. My secretary will get them an appointment, and she'll be like, okay, the referral can come. Let's just get you on the roster so you have an appointment within a few weeks. And then in the interim, just, get your referral from a walk-in or from the family doctor, but at least you've gotten in and gotten your spot.
Thank you very much. Another question from Christine. Is fertility research in a higher volume, new discoveries, or a bit stagnant due to low funding? Meaning that, yeah.
Yeah,
You
it's
know
a
what I mean?
great question. I
Mm.
mean, the thing about reproductive medicine is that, because it's such I hate to use the word expensive, but the treatments are expensive and it's an expensive field, there is money in it. And so a lot of the research, where in other fields like cancer and things like that, I shouldn't really use cancer because cancer also has a lot of private funding. But if you consider other medical disorders, it's really kind of researched at the university level. Whereas in fertility, there's a lot of private funding. There's a lot of femtech companies. Like I can highlight a recent like big innovation that's come out, and you've probably seen it on social media, and it's by a company called Gametogen, and it's a novel technique called Fertilio, actually, I should say. I actually was moderating a session last year at CFAS where one of the big PhDs who was part of the company was giving a talk on it. And so just in a nutshell, it's basically kind of improving the patient experience by doing less injections for IVF and extracting the eggs at an earlier stage, so you don't have to go through these 2 weeks of injections, bloating, and all the symptoms of making the eggs really big. You extract the eggs when they're more immature, and they've created a culture system, like a system in vitro that replicates the ovary to grow these eggs, and they've actually proven a pregnancy. So this company, Gametogen, is a privately funded, private equity backed company with all these researchers involved. And so they're able to have all these trials in various countries and advance the field. And so there are a lot of different companies like that. I'm part of some of the technology companies in Canada. And so to simply answer your question, sorry, I'm giving you a long-winded answer, but I think there's plenty of funding that's there to sort of propagate these novel technologies.
Thank you so much, Prati. I don't think we have any more questions. So yeah, I think that's the end of the webinar. Thank you so much. It was highly interesting, actually, and I get that the message out there is you need to consult as soon as you can if you want to, because it's always better to consult early than later. So
yeah, that was the message I was trying to get across. So hopefully that
yeah.
transpired well, but I also wanted to
Yeah.
sort of illustrate common diagnoses and how they could look for patients and what the options are. So
Yeah.
yeah,
No,
great.
thank you so much. Last few things about this week. We have a green ribbon campaign going on at the moment. So we sell green ribbons. It's $5 each to create more awareness about fertility issues. If you'd like, you can order them from our website and show your support. And as Prati said in her presentation, our application platform is currently open. You can find our application form on our website, so www.fertilityfriendsfoundation.com. Go to the grant application page and you will see the grant application form. The English version of it is on our English website, and the French version of it is on the French website, so you have the choice of both. And you can always contact us if you have any question, info@fertilityfriendsfoundation.com. Thank you so much again, Prati. Thank you, everyone, and have a good night.
Bye, everyone.